Hello, guys. A warm welcome to all of you. Now the INI-CET exam is over. We are here to discuss the physiology questions asked in the recently concluded INI-CET November session. As I saw the questions in physiology, majority of the questions are clinical physiology and application-based questions. But what I uniformly understood is that even though the questions may appear new to you, if you're clear with the concepts, you can apply those concepts and you can definitely derive the correct answer. This is what the ultimate theme for all the future exams, my dear friends. You are very clear in your concepts. Your concepts are strong. The question may appear slightly difficult, but inside, if you apply that concept, you can definitely get the answer. I'll show you a lot of examples here. It's a very beautiful exam. I like this physiology questions in particular. Let me show you. First question. What is this question, sir? Picture-based MCQ. See, mechanical nociceptors and its response to a probe with first blunt object, okay? Second, a pinprick stimulus. And third, with a toothed forceps with serrations, toothed forceps, is recorded as an output of a force transducer coupled to a stimulator. What would be inferred from this? See, this is the picture. For our information, this is the recording of a nociceptor. This is the recording of a nociceptor. This is the recording of a nociceptor. So what all stimulus we are giving with the help of a blunt object, needle, pinprick, and a toothed forceps. So the inference here is very simple. In central nervous system examination, particularly in the general census during our undergraduate period, if you get a CNS case, for example, what we do, particularly for pain sensation checking, we use a pinprick or a toothed forceps. That is what they have shown here. You know the concept already. See, pinprick is going to stimulate our pain receptor. Toothed forceps is going to stimulate our pain receptor. But just think by yourself, close your eyes and think. Pinprick under toothed forceps. Just apply the toothed forceps. For example, here, the pain will be maximum. That is what we are seeing here. See, the firing from the nociceptors are maximum when pressed with the toothed forceps. The firing is the needle, obviously. Pinprick with the help of a needle is going to stimulate our nociceptors and pain. But with the blunt forceps, you are clearly seeing there are no response. Look into the options. There are no response from the nociceptor when stimulated by a blunt forceps. Yes. Pinching with the toothed forceps causes stimulation of no. Nociceptors. Definitely pain will be there, maximum pain. Correct? Pricking with the needle does not stimulate, no, does stimulate nociceptors. Finally, shower pain is carried by A delta. C fibers are for slow pain. Sharp pain, first pain is by A delta fibers. So, what is the inference? There are no response from the nociceptor when stimulated by blunt forceps. True. Because this blunt forces is going to apply pressure sensation. The magnified diagram of the picture which is given here, the answer is obviously A. That is the inference. Now the diagram, look very carefully. This is the blunt forceps. It is going to apply a pressure. Now in the next upcoming exam, in the another exam which is going to come, they will ask you, if it is not stimulating nociceptor, then what it is going to stimulate? This blunt forceps, pressure sensation, a form of deep touch. I told you, remember P for T, pressure sensation. Definitely, it can activate a excellent Pacinian corpus. Nociceptors are not stimulated with the help of blunt forceps. This blunt forceps pressure can stimulate a Pacinian corpus. You can feel the pressure sensation. This needle, definitely pain. Toothed forceps, maximum pain. This is the inference. Simple question. We know the concept already. Just application of that concept will get you the correct answer. It's a brand new question. That's why I told you I like this and physiology questions in particular. Second, see, again we know the concepts already. Choose the correct option from the given statement of Enteric nervous system. We all know this enteric nervous system is considered to be a little brain. That is why we say gut feelings. See, trust your gut feelings always. It's very true. Trust your gut feelings. Enteric nervous system, physiology. First option, we are going to choose the correct option. Vagus is the only efferent from gut faults. It is both vagus, that is parasympathetic, and sympathetic nervous system through prevertebral ganglia, sympathetic nervous system, parasympathetic through vagus. So the afferents are not only vagus, both sympathetic and parasympathetic. Functions independent of brain and the spinal cord. Very, very, very true, my dear friends. That is why it is called as little brain. It can function independently of brain and spinal cord. Myenteric plexus is in the lamina propria. No, 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 no. It is not in lamina propria. Myenteric plexus is in between longitudinal and circular muscles. It is not in the lamina propria. Exclusively under the influence of nerves? No. Then for what role this gastrin, cholecystokinin, secretin, serotonin, why these guys are there? Are they simply waste? No. They can also activate our enteric nervous system. So, exclusively under the influence of nerves is false because they can be also under the control of gastrointestinal hormones. Yes. Parasympathetic connects enteric to central nervous system? No, this is what I told you. Both parasympathetic and sympathetic. It is the autonomic nervous system, to simply remember. So, both parasympathetic and sympathetic connects enteric to central nervous system. So, what should be the best answer? Choose the correct option. Who is correct? Number 2 is correct. Where is number 2? Option D. Computer G, click option D. Yes. Marks are awarded to you. D is the answer. Simple. Next. Element lesions are associated with. Element is lower motor neuron lesion. See, very simple, guys. Again, whenever you see any question, immediately the concept should flash in your mind. If that concept flashes in your mind, your preparation is very, very, very strong. No question will disturb you. What is the concept? What I told you? Lower motor neurons. Remember, they are directly going to supply our skeletal muscle. True. Alpha motor neuron, gamma motor neuron, they are directly going to supply our skeletal muscle, but upper motor neurons are not. Upper motor neurons can regulate lower motor neurons, but it is the lower motor neuron which is going to supply our skeletal muscle. So, in lower motor neuron lesions, skeletal muscle findings will be predominant. What are the skeletal muscle findings? Fasciculations. Excellent. Decrease in muscle tone. Excellent. Hypotonia. Decrease in muscle tone. Spastic paralysis you see in upper motor neuron lesion. Babinski positive you see in upper motor neuron lesion. So fasciculations, one more important finding. For example, you can also add the typical muscle finding. What is that? Atrophy of the muscle. Fasciculations, atrophy directly related to the skeletal muscle you see in lower motor neuron lesion. Reduced muscle tone you see in lower motor neuron lesion. So lower motor neuron lesions are associated with first and fourth. Spastic paralysis, Babinski positive you see in upper motor neuron lesion. Now, a very important table, my dear friends, this is what I told you. This atrophy and the fasciculations are highly classical of lower motor neuron lesions. Not seen in upper motor neuron lesion. Tone is spastic. Tone is reduced. Where tone is reduced in lower motor neuron lesion? Spastic in UMN. The distribution of weakness. Imagine an upper motor neuron lesion patient. They will come with hemiplegia, hemiparesis. That means one region is affected. Upper limb is affected region. Lower limb is affected region. On the other hand, lower motor neuron, that particular spinal segment will be affected. Segmental lower motor neuron, regional upper motor neuron lesion. Reflexes are hyperactive, exaggerated in UMN, hypoactive or absent in LMN. The most important thing, this is the first thing all experienced clinicians, they'll simply do with the help of a keychain. in this important test, Babinski sign, to find out human or element. See, the normally Babinski negative means it should be plantar flexion. Babinski positive means it is dorsiflexion. So this Babinski positivity of the great toe. This Babinski sign is positive, it is present. Means, remember, Babinski positivity present is upper motor neuron lesion. This Babinski sign is negative in lower motor neuron lesion. So this was the question. Very simple. We put the question again. The question is about the lower motor neuron lesion. So decrease in muscle tone and the fasciculations. Babinski positivity is in upper motor neuron lesion. Spastic paralysis in upper motor neuron lesion. So what is the answer? Option D, 1, 4 correct statements. This is the discussion we had. Next question. Physiology and medicine, particularly the deep sea medicine, not seen in decompression sickness. What is this disorder, sir? It is none other but our Caisson's disease. Visual loss will be seen, hearing loss will be seen, coagulopathy will be there, but it is not hemodilution. This is not seen. Answer is C. See, again, a very, very, very beautiful concept. I don't know how many of you guys are sitting inside the exam hall and seeing this question. This triad comes in your mind. What is the triad? I will show you. But before that, what is this Caisson's disease, sir? Remember, it is also called as other name. We all know it is the decompression sickness. Excellent, sir. Decompression sickness, the question. It is exclusively because of gas bubbles. Which important gas? Nitrogen. See, just imagine cool drinks, Coke bottle. The gases are compressed. If you open that cap of the Coke bottle, immediate decompression and gases will come out as bubbles. That is the simple logic in Caisson's disease. Which is going to be toxic here? Nitrogen gas bubbles. This nitrogen can cross the blood-brain barrier, going to affect our central nervous system. This can lead to a very important finding. What is that? Nitrogen narcosis. Nitrogen narcosis is possible in Caisson's disease. This bubbles, remember, it is the bubbles, can affect our joint spaces, can affect our lungs, can affect our blood vessels, joint spaces, joint pain, we call bends, lung, particularly difficulty in breathing, gas bubble occlusion, chokes. In the blood vessel, remember, most importantly, it can lead to gas embolism. Not only that, one more important finding, this nitrogen bubbles mechanical effects of occlusion. This is what I told you. One very important triad. Does it come in your mind? Instead of exam hall, what is that triad, sir? This is none other but our very well known Virchow's triad. See, this nitrogen bubbles occlusion, correct, is going to cause stasis of blood flow. Because of the endothelial injury will be there, hypercoagulability will be there. We see one option in the question, right? Coagulopathy. Yes, hypercoagulability will be there, but this endothelial injury, because of stasis of blood flow, why nitrogen bubbles are occluding the blood vessel? This can simply lead to capillary leak. Endothelial injury means capillary leak, leading to extravasation of plasma. This extravasation of plasma leading to hemoconcentration. Very beautiful. So it is not hemodilution, it should be hemoconcentration. The basic concept here lies in remembering Virchow's triad and its application. So endothelial injury, capillary leak, extravasation of plasma leading to hemoconcentration, not hemodilution. Caisson's disease, very important. Next question. Which receptor contributes to static 2-point discrimination? Again, touch receptors. Nowadays, every exam they're asking a question. 2-point discrimination exclusively means it is about a slowly adapting receptor. This is the first point that should come in your mind. Slowly adapting receptor. The best answer for this is the slowly adapting one is Merkel cell. Option A is the correct answer. Anywhere, any other sources, if it is mentioning any other answer, no, please don't go with that. The answer for this question is Merkel cells. Touch receptors are 4 in number, we all know. 2 are superficial, this first one and second one. Superficial, we can see. Which are all they? Yeah, Meissner and Merkel. This third and fourth, they are deep. Who are all they? Pacinian corpuscle and Rufinician. See this Pacinian in the very first question I told you, a deep touch with the help of a blunt forceps can stimulate a Pacinian corpuscle. So Pacinian is for pressure and vibration. So 2 are superficial, 2 are deep. Simple to remember. Meissner corpuscle, just remember an ant crawling in your skin. The gentle strokes it is making, you can easily find out with the help of Meissner corpuscle. It is superficial. Merkel cells are highly sensitive to edges, corners, braille reading, blind people. Remember, we can also write 2-point discrimination. Merkel cells. Pacinian corpuscle, I told you P for P, pressure and vibration. Rufinus endings are sensitive to skin stretch. Now, the most important concept. Always remember, guys, the corpuscles are rapidly adapted. That means what? Meissner corpuscle, Pacinian corpuscle are rapidly adapted. The remaining 2 ones are slowly adapted. Merkel cells and Rufinus ending. So this question 2-point discrimination is about a slowly adapting receptor. And the best slowly adapting receptor here is Merkel cells for 2-point discrimination. This also in a blind people, braille reading, it is the Merkel cells. Done and dusted, no more controversy. Always remember Merkel cells. Blind people, braille reading, slowly adapting receptor, 2-point discrimination. Yes, static 2-point discrimination. Next question. Now look into this question, guys. Like touch receptors, sarcomere is ubiquitous. That means it is universal. Everywhere, any exam for that matter, sarcomere are favorites. And particularly in this question, uniformly all the students told the arrow marks were there, but the alphabets were not marked. So, but to answer this question, we know the concept already. Which band is which one? A, B, C, D, just for our understanding. See, what is this A? The boundary line, Z line. What is this B? The light ones, I band. What is this C? The dark ones, A band. And what is this D? It is the H zone. Look, they marked it in the H zone. So what is the answer for this question? Very simple. It is Z line, I band, A band, H band or H zone. So now diagram to understand this concept. See guys, the boundary for a sarcomere is always the Z line. Inside the Z line, you will definitely see actin and myosin. In the center one is our myosin. These peripheral ones, these thin filaments are our actin. Actin and myosin are overlapping. We are clearly seeing actin and myosin are overlapping in the sarcomere. In the middle, you will see one line. What is this line, sir? M line. Very important. In the middle, you see M line, which is the band that is formed by the thick filaments, myosin. Remember, guys, this one. This is in the center. What is this? This is the A band. Yes. Comprised of myosin predominantly. It is the A band, the dark band. The ones that is predominantly formed by our actin. This is the I band. We are seeing formed by actin predominantly. Actin and myosin are overlapping, but one particular region we are clearly seeing. There is no overlap between actin and myosin. It exactly looks like which important alphabet? It looks like an alphabet. What is this alphabet? And this alphabet is the H zone. The center one is the M line. The part where there is no overlap between actin and myosin is H zone. That's all. So what to remember from this diagram, guys? The boundary line is formed by Z line. Z line is the boundary. The center one, dark band, is the A band. The peripheral one, light band, is the I band. The middle line is the M line. The non-overlapping part, the non-overlapping portion is the H zone. See sarcomere? Definitely a very high yield question. Next. Match the following hormones with their receptor. Very simple, guys. Simplest out of all the simple questions. Insulin, remember, I told you, insulin, I, two I's. Tyrosine kinase, two I's. So it is A. Acetylcholine is definitely a ligand gated. Growth hormone, I told you many times, JAK-STAT pathway. Thyroxine, direct nuclear receptor. So what is the answer here? C. A is 3, B is 4, C is 1, D is 2. Excellent. The answer is C option here. Again, receptors, particularly this thyroxine asked many times nuclear receptor, growth hormone, erythropoietin, leptin, recent questions, JAK-STAT pathway, very high yield. So receptors, insulin, obviously tyrosine kinase receptor, many times asked the question, very high yield one. Next. Another important question. See, all from favorite topic, guys. Physiology. Oxygen dissociation curve. Again, we know the answer here. The oxygen saturation with respect to PO2 is marked as A. What happens to the oxygen hemoglobin dissociation curve upon transfusion of stored blood? So stored blood, obviously, which shift? Left shift. So which one is the left shift here? This B is the left shift. So the answer for the question is curve B here. That is given as option A. So the curve B, this is the left shift. So important points for left shift. First and foremost, the predominant thing for left shift is falling carbon dioxide, guys. This falling carbon dioxide means falling H plus ion, which means rising pH. We call alkalosis. See, two L's. Alkalosis, left shift, hypocarbia, left shift. This is obviously our left shift. This is our right shift. This is the normal sigmoid shape. Another important point, which hemoglobin left shift? Fetal hemoglobin. Not only that, why? What is the reason? Concept. Because fetal hemoglobin having low affinity to 2,3-DPG. Which poisoning? Carbon monoxide poisoning. And the answer for the question, stored blood. Why stored blood? Because stored blood, there is fall in 2,3-DPG. Always this 2,3-DPG is for right shift. Fall in 2,3-DPG, an intermediate product of glycolysis. This fall in 2,3-DPG means stored blood. See, in this stored blood, there is fall in 2,3-DPG, which is not a desirable situation, guys. That's a practical thing, what you need to remember. So, what you have to do in stored blood to prevent this fall in 2,3-DPG, a very special medium we use. What is that? CPDA? Citrate phosphate dextrose adenine. Just to store blood in this, there is less falling 2,3-DPG, which is actually very good. So stored blood normally have fallen 2,3-DPG and the left shift. To prevent this, we normally store this blood in CPDA. There is less falling 2,3-DPG. So fetal hemoglobin asked many times left shift, carbon monoxide left shift. Now this time they asked the stored blood left shift. Simple. Next. Peripheral chemoreceptors are most sensitive to no other doubt. It is always hypoxia. That is why, as a part of evolution, in this peripheral chemoreceptors, we have something called as glomus cells. These glomus cells are the oxygen sensors. They are not seen in central chemoreceptor. They are exclusively seen in peripheral chemoreceptors. They are the oxygen sensors. Most importantly, that is why they have something called as oxygen sensitive potassium channels. They're all not waste. As a part of evolution, we evolved all these important things only in the peripheral chemoreceptor to sense hypoxia. There is something called as oxygen sensor. That means they are more sensitive to hypoxia. No other answer. Peripheral chemoreceptors are always most sensitive to hypoxia. That is why we have oxygen sensor there. That is why we have oxygen sensitive potassium channels there. The answer for the question is hypoxia. Option B. Yes, peripheral chemoreceptors. Next. What causes decreasing GFR? This is exclusively based on a very important law. What is that law? Newton's third law. What is Newton's third law, sir? For every action, there is equal and opposite reaction. Remember that. The answer for the question is option A, decrease in glomerular coefficient. What is the meaning? We have a discussion. See, guys, this is the afferent arteriole, this is the efferent arteriole, this is the glomerular capillary, which is going to filter the fluid into Bowman's space. What is going to act here? A very important group of forces. The name of these forces are Starling forces. What are the Starling forces? First and foremost, the major one that favors filtration. Look here, favoring filtration. What is that one? Hydrostatic pressure in glomerular capillaries. We call this as PC. The value is usually around 60 millimeters of mercury. It favors filtration. That means if this value increases, there will be increase in GFR. That's all. Another important concept, it is considered to be the action. Filtration is the action. We are going to oppose this action, Newton's third law. Now the arrow mark direction is going to be ulta, opposite, because these forces are going to oppose. How many forces? Two forces. We are going to oppose this filtration. The first one is the oncotic pressure in the glomerular capillary, which is usually 32 millimeters of mercury because of proteins. We know oncotic pressure means protein. And in the Bowman space, hydrostatic pressure. This hydrostatic pressure in Bowman space is usually around 18 millimeters of mercury. That means what? A 60 millimeters of mercury favoring filtration, 32 and 18 are opposing filtration. We need to understand net filtration pressure, the ones that favor filtration minus those opposing filtration. 32 plus 80. How much is this? 60 minus 50. The net filtration is 10 millimeters of mercury. All this we know. Very, very, very simple. That means what? Opposing filtration, if there is decrease in oncotic pressure in glomerular capillary, means it increases GFR. If there is decrease in hydrostatic pressure in Bowman space, means it increases GFR. That means what? Increasing hydrostatic pressure of capillary increase GFR, but decreasing oncotic pressure, decreasing Bowman space hydrostatic pressure increases GFR because these two forces are opposing our filtration. Now, why I am telling this point? This is relevant to our options. So this increase in PC increases GFR. This fall in oncotic pressure, fall in hydrostatic pressure in Bowman space increases GFR. Now, remember guys, GFR calculation, it equals Kf into net filtration pressure. How much is the GFR, sir? We know 125 ml per minute. What is this Kf, sir? We now know net filtration pressure 10. So what is the normal for value for this filtration coefficient? It is usually 12.5. So 125 divided by 10, 12.5. This filtration coefficient is very, very, very important. If this filtration coefficient increases, means GFR will increase. This filtration coefficient is determined by our glomerular capillary and its surface area. More is the surface area, more will be the filtration. More is the filtration coefficient. It is determined by the glomerular capillary surface area. For example, if the surface area is reduced because of destruction by excess blood glucose levels, diabetes mellitus. So in a diabetic patient, decreasing GFR can be because of decreasing filtration coefficient. Why? Because glomerular capillaries are destroyed. Less surface area, less filtration coefficient, less GFR. So what is the value for this filtration coefficient? 125 divided by 10, it is 12.5. So with this idea, look into the question now. What is the question, sir? Simple. What causes decrease in GFR? Decrease in glomerular coefficient decreases GFR. Yes. Decrease in glomerular oncotic pressure increases GFR. That's what I told you. Increase in glomerular hydrostatic pressure increases GFR. Decrease in Bowman's hydrostatic pressure increases GFR. What causes decrease in GFR? What causes decrease in GFR? Option A. Decrease in glomerular filtration coefficient. So the answer for the question is option A. Simple. We had a very beautiful discussion. Again, this glomerular capillary and the Starling forces, Newton's third law, very high yield always. Physiological dead space, PDS. Can be measured by spirometry? No. It is measured by an important equation that is called Bohr's equation. Is lesser than anatomical dead space? No. Usually in all healthy individuals, physiological dead space equals anatomical dead space. Represents inadequately ventilated alveoli? No. It is always the inadequately perfused alveoli, P for P, physiological dead space. Now, what is the simple meaning, sir? Look into this diagram, guys. The answer is B. It's very simple. What are the dead space types? See, in conducting airways, what we have is anatomical dead space. In this alveoli, one side a good ventilated alveoli, good perfused alveoli, we will have the ventilation perfusion ratio. There will be no physiological dead space. On this side, this alveoli is ventilated, but there is no blood here for gas exchange. That means this air is wasted. You get a dead space here, physiological dead space. Simple logic. Good ventilation, good perfusion, good gas exchange. No dead space. Well ventilation, no perfusion. Wasted ventilation, physiological dead space. That's all. So it is the inadequately perfused alveoli. That is the physiological dead space. Perfusion, P. Physiological dead space, P. Simple. Next. What contributes to the latent period of muscle twitch? In the previous exams, we asked a calculation-based question on this muscle twitch. That is recognizing frequency, you know. Now they asked about the same topic, but about the latent period. What is the reason for latent period? Neuromuscular transmission contributes, EC coupling contributes, transmission impulse from nerve contributes, but this reuptake of calcium back into sarcoplasmic reticulum is a process for relaxation. So it does not contribute. So what are all the contributing factors for latent period? 1, 2, and 4. It is not 3. What is the meaning, sir? Now look into this diagram, guys. Very simple. In response to a stimulus, this upstroke is the contraction, this downstroke is the relaxation. But this contraction and relaxation will not happen immediately. There is a small time gap to get the response. What is this small time gap? This is our latent period. The small time gap is the latent period. What is the cause for this latent period, sir? See, very simple. You are stimulating, immediately no contraction. After a small gap, there is a contraction. Because after stimulation, first an action potential should be generated. This is our so-called nerve impulse, correct? Then neuromuscular transmission happens. What is the meaning of neuromuscular transmission, sir? Acetylcholine must be released in the neuromuscular junction. This is neuromuscular transmission. This acetylcholine must act in the neuromuscular junction, ligand-gated receptors, sodium influx, further leading to calcium influx, all leading to excitation contraction coupling with the help of calcium. Then troponin C, calcium, unleashing actin and myosin, the binding sites, interaction of actin and myosin, their contraction. So contraction happens. So following contraction, this calcium have to be taken back into the sarcoplasmic reticulum for relaxation. This process does not contribute to latent period. What contributes to latent period? Nerve impulse, neuromuscular transmission, excitation, contraction, coupling, eventually leading to contraction. But what is for relaxation? This calcium is taken back into sarcoplasmic reticulum. This process does not contribute to latent period. So what all contributes, my dear friends? First one is obviously transmission impulse from nerve. Second one is neuromuscular transmission. Third one is excitation contraction complex. So the answer is 1, 2, 4. Good. A very beautiful question indeed. Which of this system do not require ATP means they are considered to be a passive process. Simple diffusion is passive. Facilitated diffusion is passive. Sodium potassium pump is active. Symports are active. This paracellular pathway is also a passive process. So 1, 2, 3. 1, 2, 3. The answer is option C. See, we all know simple diffusion, facilitated diffusion, active transport process. What is this paracellular part, sir? See, if the transport happens through the cell, that through is transcellular. On the other hand, if it takes a shortcut, that means what? We are clearly seeing sideways. Okay, this is sideways or lateral. See, this is sideway movement. That means happening in between two cells. This in between two cells. If it is happening through a cell means transcellular. If it is happening in the side, in the gap, this is sideway lateral movement is paracellular route. This paracellular route is usually happening by diffusion. Very important. This diffusion, simple diffusion is a passive process. So paracellular pathway, sideway movement, not through, sideway movement, lateral movement. Because of diffusion, simple diffusion, it is a passive process. So what should be the answer? Paracellular is passive, simple diffusion is passive, facilitated diffusion is passive. It does not require energy in the form of ATP. All right, guys, these are the questions we got in this session, INI-CET. It is very obvious your inference. Majority of the questions are from previous year topics. Okay, the questions are slightly twisted. You can see GFR, you can see sarcomere, you can see oxygen dissociation curve, passive process, active process, all are from the previous year repeat topics, except one or two new questions that also, if you are conceptually strong, for example, pathology, you learned about the virtuous triad. Caisson's disease, you can apply that virtuous triad, hemoconcentration. This is what I told you. You know the concept already, just apply that because asking directly the questions is no fun, right? Just think and answer. You can easily do that. Any number of questions they can ask. If you are conceptually strong, it is very, very good. You can definitely crack your exam. So be conceptual. Always have your concept strong. Whatever may be the pattern of the exam, it doesn't matter. What matters is your rank, and you will definitely get that. You will definitely get your dream PG seat and your dream life. With that note, we'll conclude this session. Good luck and best wishes, my dear friends. As always, thank you. Bye bye.